Standardizing nursing management of fecal incontinence in critical care patients, a quality care improvement project by myself, Rebecca Caprio. As all nurses know, pressure ulcers are a major concern in any hospital setting. Following a new pressure ulcer development, it can cost the hospital $5,000 to $50,000 lost. Nationally, the pressure ulcer rates in the ICU setting range from 8.8 to 41%. My workplace has a prevalence rate currently, as of 2017, of 10%. Prevalence is any pressure ulcer coming in or leaving the ICU. Our incident rate is slightly less at 8.7. Incident rate is calculated on any newly developed pressure ulcer 48 hours after admission. This is the more important rate we calculate because it's a preventable pressure ulcer at that point, since it is developed after being in our care for 2 days. With critical care patients, sometimes it is contraindicated to turn and position them often. So we have to do other things to avoid developing pressure ulcers, such as keeping the skin clean, dry, and intact from incontinence-associated breakdown. My unit's current pressure ulcer bundle in the screening tool fails to recognize the unique needs of incontinence patients. That is why I have decided to address this issue in my unit. In order to begin implementing a change, I needed to pull together a multidisciplinary team in order to ensure we had unit-wide collaboration and compliance, as well as the necessary help and expertise from multiple nursing leaders and physicians. My team included the following: my unit manager, who is an RN BSN, and she helped identify the problem, develop the aim, as well as ensuring compliance and providing education. The critical care educator also aided in developing the aim, and she is in charge of educating the newly coming critical care nurses that are coming up and starting their training. So she'll train them fresh out of their orientation, as well as helping new or in-place nurses learn the process and what we're going to try to accomplish with this intervention. I included both day and night shift team leaders who are in charge of helping collect surveys, gather opinions, assess the need for changes in the intervention, as well as ensuring nursing compliance with updating their education regarding the intervention I've chosen to use. Lastly, I included a SCIM team nurse practitioner. They usually only round about once a month as needed, just for education purposes, but I wanted to make sure I included them because they know best how to treat incontinence-associated dermatitis, as well as how to prevent it, which could lead to the development of a pressure ulcer. So she was able to offer to come in twice a week and assess some skin, as well as update nurses and answer questions regarding the use of camelceptine. With my critical care nurse educator and the help from my unit manager, we developed an aim for the project based on last year's ICU pressure ulcer rates. After intervention implementation, our goal is to reduce the incidence of ICU acquired pressure ulcers to 6% or less within 12 months. Looking at the graph below, you can see a general timeline of the 4 months already achieved in the implementation process. Around the middle of February, education sheets were handed out to nurses to update them on the use of camelceptine, when to use camelceptine, when to not use camelceptine. You could see our rates drop to 7% by March. There was a disconnect there in March with some of the physicians in ordering of camelceptine, and it did go back up to about 8, but it is still less than our current last year's rate of 8.8%. I feel in 12 months that this will trend back down with overall compliance and the use of PSA cycles. My unit currently utilizes the Braden scale during charting to determine a patient's risk for developing a pressure ulcer. The Braden scale does not address fecal incontinence. It only considers moisture as a risk factor. Moisture can be considered present for many occasions, someone who is sweating, for DTs, or someone whose catheter is leaking. It does not specifically address fecal incontinence. Fecal incontinence and circulatory compromise are the biggest influencing independent factors in the development of ICU hospital-acquired pressure ulcers. In one study, nearly half of ICU-acquired pressure ulcers developed on the sacrum, the hotspot for fecal incontinence. In order to effectively reduce the rates of ICU pressure ulcers, all risk factors must be considered and addressed. Every shift does complete every 4-hour gastrointestinal assessment. However, the bowel movement documentation screen does not include incontinence as a choice. The nurse must freely type in incontinence if she decides to do so, otherwise it is not documented. Physician notification must be made once there is more than one episode of fecal incontinence. Physicians should order protective barrier cream once they are notified. That way this can be addressed next cleanup for that patient. The Omnicell will stock the ointment, and then nurses must have it in the room and scan it into their electronic medical administration record. That way we can ensure that nurses are being compliant and that the ointment is in the room in case needed for a next routine care. Here's a quick look at the Braden scale we use in our ICU. There is an error at the bottom. You could see at very high risk it says greater than 9. However, it should say less than 9. Nurses know this in our unit. Most of our ICU patients range from about a 14 to less than 9. So they are moderate risk or go all the way up to very high risk. We rarely have a patient who is a low risk. You can see under the moisture section that it does not specifically address fecal incontinence. However, you do have 4 choices of constantly to rarely moist. So there is some degree of consideration there. However, some nurses don't consider fecal incontinence as a moisture exposure. That could be a matter of education, where they went to school, what they were taught. As well as lack of protocol here in the unit, which is what I am addressing. In my first PDSA cycle, my pilot cycle, I did plan to test the ease of use and increasing intervention use was my goal. And the question I asked was, would MD order requirements reduce the rates of use I figured that if nurses did not need a doctor's orders, that it was something they could get on their own, that they would be more likely to use it. So I did offer that. I did provide education regarding a silicone-based barrier cream that did not require a physician's orders. And then I did study what they were doing, and I also got survey results and asked them what they thought and if they thought it was working or not. I found that nurses were not using it as often as I had hoped. They were either busy or forgot about the intervention altogether or used their own method of prevention. So I did map the data at the bottom according to the results. You could see for the first week of this PDSA cycle that the number of incontinence patients is the dark blue. We did have a matchup on day 2, right after education, and some of the staff was present for those 2 days in a row, and they did use the silicone-based barrier cream. Then by day 3 and 4, there was a decline in the use of the ointment, and then you can see all the way by day 7, there was a total lack of use of the silicone-based ointment. Not one patient received it for that day. Then I had to develop a PDSA cycle 2. For my second phase of my PDSA, or my implementation phase, I did plan to obtain the results I needed for change, and I did determine the lack of compliance from my previous PDA cycle. And I asked a similar question, and I said, do doctors' orders of ointments, do they get used more? Are nurses who are forced to use ointment going to use it more? I did educate physicians. I had 2 attendings on board who notified their residents about the need for this treatment and how to implement it and how to order and what to order. And I did educate nursing staff again on the change on chemoseptine ointment. It is different than the silicone-based, and it does require doctor's orders. They did receive a handout as well as an email with an online clip and a little thing from the critical care educator who she sent out, and there was signing required. So nurses who had read the updated information were required to sign, so we know who had been updated. Then I did study the results of the ongoing intervention over the course of a few months, and I did along the way obtain survey results from the nursing staff on their opinions about it, if they thought it was easy to use or if they thought it was effective. And here the results are mapped below. You can see in January, we had a high number of incontinent patients and a low number of patients receiving the preventative ointment. That had really not been implemented yet, and we are still kind of tossing up the silicone-based ointment at that time. But by February, you can see that the number of patients receiving the ointment had risen, and the pressure ulcer prevalence rate was still high. And then by March, we almost had a match there with the amount of incontinence patients versus the number of patients receiving preventative ointment. And there was a drop in the percentage of patients with a pressure ulcer for that month. And then by April, more patients were receiving preventative ointment than there were a number of incontinence patients. There was a patient on the unit on a heparin drip who was menstruating. So the nurse took it upon herself to tell the physician that even though it wasn't fecal incontinence, she was being constantly exposed to moisture based on her menstruation. So she was considered in the study here. So we had more patients receiving the ointment than that were incontinent. And you can see there was a slight rise in the percentage of patients with a pressure ulcer, but it's not always going to be a steady drop, but the goal still over 12 months is to be below 6%. Implementing the change, I found, was one of the hardest things to do of this project because it requires unit-wide compliance as well as willing attitudes and opinions. Some of the facilitators for my implementation was the innovation, so I had a multidisciplinary team that brought lots of ideas, was willing to help and recognize the need for change, as well as the nursing staff re-education renewal. So it was the time of year where nurses were being required to renew some of their education and revisit some of the things, and it's all online. And there was emails sent out, so they were able to see the emails and read the handouts as well as view the handouts, and then they could sign them. So they were in the mood to be updated on some of this information, and they were able to revisit the last year's rates and kind of see where we needed an improvement. So it was readily adopted to that point, and it was something that was easy to measure because it's something we always calculate anyways. So we're always keeping track of it week by week, month by month, and nurses don't want their patients to develop pressure ulcers. Physicians are always in the unit at all times, especially residents, they're there all night as well. So there's always someone you can just walk up to and say, hey, can you order this for your patient? And they're there. Some of the barriers, it's a larger number of nurses, it's a pretty big unit, so you have to make sure that everyone's receiving the education. It could take a little extra time. Because it's a big unit and it is a teaching hospital, there is frequent changes in physician care. One doctor, it might change the next day to a different attending, as well as the residents change out on a daily basis. So they all need to really be updated and know what's going on. Understaffing is an issue. There's a lot of vacations happening around this time. It's illness season as well as nurses being out on sick leave. So it's kind of an issue as time. Nurses don't have the help from aides all the time, and maybe they can't turn or clean up the patient as often as they like. And if they do, they don't have the ointment ready. And it does take extra time to put it on versus just cleaning them up real quick and putting them back. You do have to open the packages and scan them into the EMR. Those were some of the barriers I found in my particular unit. When considering spreading the change hospital-wide to units that needed it, that had also patients that were a little more dependent on nursing care and that were fecally incontinent, some of the facilitators on those units would be large multidisciplinary teams. They would have to go on a larger scale with many nursing leaders, management, pharmacy, physicians. The system for education is very updated. Nurses are emailed. They're required to check their email, so they know every shift they work, what's new, what's going on, what they need to be doing, completing. They can log on the internet and complete their education that way as well. Nurses practice in this hospital using evidence-based knowledge. We get frequent flyers. We have seminars that are paid for. They fund us to go to seminars and get certifications. So nurses are used to being on the up about evidence-based knowledge and education. We also have the use of the EMR and OmniCell system to prevent medication errors and also to ensure that nurses are administering the medications they need. There is no ability to double-click past. You do have to scan the patient and scan the medication. So that ensures that the ointment is in the room with that patient. That way the next change for that patient, that you can ensure that ointment is in the room and the nurse will use it. Some of the barriers to moving it into the larger setting is the large number of staff that it is needing training or education. Sometimes it's hard to keep track with larger numbers who is updating and who needs who has questions and concerns about it. There are old habits of care. Some of the nurses that have been there a long time or a culture on a unit could change their attitude or opinion about using the Camel-Septine ointment. As well as the whole hospital is a teaching hospital, there are frequent changes in physician care. The cost of the ointment should always be considered. It is a burden for the hospital, but if it could save them thousands of dollars from a pressure ulcer developing, then it is huge. There is already shown improvement on the PU incidence in the short months of initial implementation. At the current rate, I believe my unit will reach the intended goal within the expected time frame of 12 months. That's the goal of the aim. If the goal is reached, not only will our unit benefit, but the entire hospital will. Once the change is spread to other units, my organization could potentially have one of the lowest PU rates nationally. The change is simple and not very costly, but could save the hospital thousands of dollars, all while protecting the patient's best interest. The goals in making an impact on quality of care is important to ensure that the intervention aligns with the goals and the interests of the hospital's goals and mission. The selected target populations and the units for implementation plans must align with the need for change. There must be a team of managers and messengers to ensure that there's compliance and updating of education for nurses. The use of email is also helpful in notifying nurses of the need for change, how to change, and the education of why to change. This is evidence-based practice. Also, we need to capture the knowledge and feedback of the nurses that are helping implement the change. This can help us conduct PDSA cycles. We can develop surveys for staff in order to make the changes necessary. When you use this on a bigger scale, if I plan to go hospital-wide, there would be more PDSA cycles needed as each unit is unique. The documentation, calculation of incontinence patients, the frequency of intervention use, and the PU incidence for each individual unit is the outcome measure. So we can measure all those things. We can keep track of the amount of incontinence patients, the frequency of the camelceptine use, and the PU incidence for each unit. And it could be charted out and made as a visual for the nurses to see the impact that they are making on quality nursing care.